So this chapter, we're going to look at drugs for treating digestive disorders. So again, this chapter will actually review some of the pathologies that we talked about in the pathology lecture on the gastrointestinal and hepatic biliary system. So some of that will be a little bit of a review, but obviously then we will get a little bit into a little bit more in depth into the treatment, the pharmacologic treatment of a lot of the digestive conditions, which, some things we will experience, obviously, as was discussed in the chapter on pathology. A lot of your digestive complaints that you're going to get from patients, for the most part, are going to be caused by, very benign things, but again, to be aware of the signs and symptoms, and then being familiar with the treatment of them particularly could help with some of the symptoms that individuals experience. So background information. So again, review the anatomy, which we discussed pretty in depth in the pathology talk, but just to kind of review, we have the upper and lower gastrointestinal tracts and the associated organs. So again, the upper GI being everything from the oral cavity through the duodenum, and then the lower gastrointestinal tract from the rest of the small intestine through the anus, and then the associated organs, the pancreas, the liver, so those other organs that assist with the process of digestion and being able to metabolize the food products that we eat, all associated with that. Be aware of, this is an important thing in sports medicine, to just be aware of the signs, symptoms, so kind of the red flags, if you will. So this chapter has a red flag notice. So be aware of those red flags as it relates to the gastrointestinal system. So shock, peritonitis, cholecystitis are some of the things you want to make note of. Again, is there fever associated with the gastrointestinal discomfort? Do they have acute bloody diarrhea with or without hemodynamic instability? Those are some of the things that you want to be aware of when you're looking at background conditions, emergency situations or red flags. So whether they're emergency situations or things that maybe need a little bit more urgent referral, that would be appropriate. Mention a little bit about appendicitis. So again, we talked about the signs, symptoms of that in pathology. So the gold standard for treating that is an appendectomy. However, there is a non-surgical approach with treatment with antibiotics, which is now also viable. And as would be that there are fewer complications with this, obviously, than with surgery. So now, again, this would be something that would be, a patient-physician discussion to have. In the case of an acute appendicitis, that would be something for the physician. But just be aware that it is a viable option to potentially treat with antibiotics. And if that's the case, then obviously there's always a risk with surgery. An appendectomy is a relatively common procedure, but like with all surgeries, there's potential for complications. So it is something to consider in the treatment for appendicitis. So nausea and vomiting. So kind of understanding what basically nausea and vomiting is. So again, it's a stimulation in vomiting center of the brain, and basically there's afferent stimuli that goes to these centers of the brain, and the idea is it's a protective reflex. So it's to, emesis is the reflex to get rid of gastrointestinal tract of toxins. So now there's other things that can also cause vomiting, but that's the primary purpose, or the reason why we're able to do this is to rid the GI tract of toxins. So we also know that it is a frequent side effect of many medications. So again, as you're going through the medications, as we always talk about, you're going to do the same in this chapter. Again, pay very close attention to the tables and charts in the text, as they kind of give some further information on some of the medications, the negative side effects, and the different names of the medications. So common causes of nausea and vomiting, some of which are going to be conditions that we talk about: gastroenteritis, which is frequently caused by a viral infection. We'll discuss later on, how to kind of treat gastroenteritis based upon what type of pathology you think is causing it. As we had said, various drugs can do this as well. Motion sickness is a common cause of nausea and vomiting, and also some of the issues related to pregnancy. So these are all various things that can potentially cause nausea and vomiting. So again, if a patient comes to you with nausea and vomiting as a complaint, there's obviously a very wide range of things. So basically, it's not nausea and vomiting is not a condition in and of itself, but it's something that symptomatically we can treat potentially with various types of medications. So drugs for treating nausea and vomiting, for those with labyrinthine disturbances, so this could include vertigo, which is the kind of a vestibular origin for labyrinthine disturbance, so people that have motion sickness, vertigo. An antiemetic or an antihistamine can be given. So look at the antiemetics in the chart in your book and just kind of make note of them. We're going to discuss some of them here with some of the other forms of nausea and vomiting and their treatment, but just kind of be aware of them. Some of them have specific types of applications depending on the individual. Another thing that could also be utilized is an antihistamine. If they're going to use an antihistamine, they should take it 30 to 60 minutes before boarding a vehicle. For individuals, this is one of the situations, if someone's going to have a large fluid loss from vomiting, there's a lot of metabolic complications that can occur from that. So metabolic alkalosis, hyponatremia, obviously just general dehydration, which will need to be treated with an IV. So there's various antiemetics that can be effective for this. Promethazine is one of them, and that could be administered intramuscularly or through IV. So it's important to note that if somebody is actively vomiting, they're going to have to take an antiemetic via a parenteral route, because they obviously won't be able to absorb it through an enteral route. Psychogenic vomiting, again, they can get relief regardless of the cause. There's various options available. Prochlorperazine is another type of antiemetic that can be utilized, and that can be administered both through a parenteral and enteral routes. So if someone has psychogenic vomiting, prochlorperazine could be an option for that one. Ondansetron or Zofran is a very well tolerated and effective antiemetic. It's actually a serotonin antagonist, so it's good for general nausea, which can be good for pregnant individuals. It's absorbed well in the GI tract, and it's metabolized in the liver with about a half-life of 3 to 6 hours. It's a long-lasting medication, and like I said, it's pretty well tolerated with minimal adverse effects. Obviously, for pregnant individuals, there's obviously some medications could be contraindicated. Zofran would be one that they can definitely take. Metoclopramide, also known as Reglan, that's another one that has a similar mechanism of action to Zofran. So that's another medication, a serotonin antagonist that can be utilized as well. So looking at diarrhea, again, diarrhea is going to be typically a symptom of another problem. So again, it's the Greek word for to flow or run through. So as we all know, diarrhea is the frequent bowel movements with loose or watery stools. So in severe conditions should be suspected in the following cases. So really watery diarrhea typically is going to be caused by something related to tainted food or an antibiotic origin. So that's something to really be aware of. One of the significant things that can happen with antibiotics is the development of Clostridium difficile, or C. diff. So that's something to be aware of. If an individual's, saying that they have diarrhea and they've, very significant amounts, you have to be aware of that. That's always a potential thing. Now, many times a person who takes an antibiotic may get diarrhea. It doesn't mean that they have C. diff, but there's other symptoms related to C. diff that you need to be aware of if that's occurring. Bloody diarrhea, inflammatory bowel disease, or even something like diverticular bleeding could cause that. So that's always something to be aware of. And then what we call traveler's diarrhea, which may have a bacterial origin. So depending on what's causing the diarrhea will kind of dictate how it should be treated. So in some instances, an antidiarrheal medication may be warranted, but in some cases you don't want to treat the diarrhea with an antidiarrheal, and you'll kind of see, how that decision kind of gets made. One big thing that it is always the case, very similar with nausea and vomiting, is rehydration is vital. There's various options for this. Your book gives a comparison. So Pedialyte it has less sugar in it and fewer calories and more electrolytes. It also doesn't have sucrose in it, which can draw more water into the intestine. So sometimes people will just go right to Gatorade, and Gatorade's not a bad choice per se, but something like a Pedialyte is probably a little bit better and a little bit more effective as far as a rehydration when somebody actually has diarrhea. So the drugs for treating diarrhea, again, non-specific antidiarrheal doesn't address the underlying cause. So essentially, when you take a medication that's an antidiarrheal, it doesn't necessarily fix the problem. It'll stop the diarrhea, but it doesn't treat the underlying cause. And that's the important thing. So again, they're medications that are fine to use for it, but you need to make sure that the underlying cause gets taken care of, or that taking an antidiarrheal isn't going to make the underlying cause worse. So, for instance, so again, the idea behind an antidiarrheal is it decreases intestinal motility. So you will kind of stop with the frequency of going to the bathroom. However, if you have an infectious organism or a condition that you're actually trying to get rid of, it's gonna potentially cause more of a problem. So for instance, C. diff patients can actually get worse as a result of taking an antidiarrheal. So again, if one contraindication for an antidiarrheal, or I guess two in this case, recent antibiotic use or bloody stools, again, you're going to want to look at the cause of that. And if someone has had recent antibiotic use, it's always a concern about C. diff. Again, antibiotics by themselves can still cause diarrhea, because basically it's going to disturb the natural flora of the intestines, but you want to make sure that they're not potentially getting C. diff. So some other over-the-counter interventions. So probiotics are very good. They could help restore that microflora that gets lost with diarrhea. So if someone's taking an antibiotic, they can take a probiotic to potentially keep their intestinal flora, as it is, and not get disturbed. So lactobacillus and the Saccharomyces boulardii are two of the more common probiotics that seem to be very effective. So, and again, they're just available over the counter. Some people take them on a regular basis anyway, for various gastrointestinal disturbances. They tend to work very well. Another over-the-counter intervention that's not necessary, that's not an antidiarrheal, that's not a direct antidiarrheal that affects the intestinal motility, is bismuth subsalicylate, which is an anti-secretory, anti-inflammatory, and antimicrobial medication. So this is your Pepto-Bismol. So basically, this tends to be very good for treating diarrhea as well, for different reasons other than just decreasing intestinal motility. Because it has a salicylate in it, as it gets absorbed in the stomach, it could cause dark stools. So one of the things is when people take Pepto-Bismol, they see their stool darken. Now remember, melena, which is dark stools caused by bleeding, is a different thing. So the individuals will get dark stools from this. It's occurring from a chemical reaction with bismuth sulfide in the gastrointestinal tract. So you may have to tell, like, somebody, if someone says, oh, I all of a sudden had, I was taking something for, a stomach upset. Now my stool seems really dark. Well, ask them if they took Pepto-Bismol. If they took Pepto-Bismol or bismuth subsalicylate, which is the generic form, that's the reason why. So they don't have intestinal bleeding. It's just a chemical reaction from the medication. So continuing on with this, again, you have anti-motility and anti-secretory agents. So again, they can treat intestinal motility and intestinal secretion and absorption. And again, so what they're basically going to do is increases the mouth cecum times and anal sphincter tone, which is going to reduce the amount of times that you will go to the bathroom. So a very common anti-motility medication is loperamide or Imodium. So this is available over the counter. This is preferred over opioids. Sometimes individuals will be given opioids in treating diarrhea, but obviously this is a much better, more tolerated medication, which can have fewer side effects. So you get achieved plasma levels in 3 to 5 hours as a half-life of 11 hours. So this can be an adjunct potentially for travelers' diarrhea. If somebody does experience that, and we all talked about the causes of travelers' diarrhea, overuse, abuse can cause constipation. It would make sense that could be a potential negative effect or potential cause of overuse. So patients with inflammatory bowel disease, there's caution whenever they take these. There is the chance that they could develop something called toxic megacolon, which is an acute colonic distension. So that's a complication of inflammatory bowel disease. So you just want to be aware of that in individuals if they do have inflammatory bowel disease and they're trying to use something to kind of treat the diarrhea. So constipation, so this is now the opposite side. This is where we have reduced bowel motility. Again, there's a wide ranges of causes and symptoms for this, some of which we've already kind of talked about. So again, make sure to look and review that. So that, again, there's various forms of irritable bowel syndrome that could cause this. There's dietary things that could cause constipation. So effectively what you're getting now is the opposite. Instead of increased bowel motility, you're getting reduced bowel motility. So instead of watery loose stool, you're getting very hard compacted stool. So again, many reversible causes. Again, the idea here is that there's excess water that gets extracted from the stool. Again, the gastrointestinal system is always looking to kind of balance the amount of water in the stool that that it takes out and allows in to allow for waste to be eliminated. And then obviously there's the decreased motility, which can lead to constipation. So drugs for treating constipation. So when you look at the intervention options, and there's various things here. Again, there's a lot of different things that can kind of be the culprit when you look at constipation. So the first thing you want to ask is to, number one, just even increasing dietary fiber. So without even looking at bulking agents or other types of fibers, like look and see. So you want around 20 to 35 grams of fiber in the diet. If they're having trouble getting fiber in the diet, there's over-the-counter fibers that individuals can take. For instance, Metamucil is one example. That's one example of a bulking agent that people can take, and the textbook gives some examples of those. Individuals can also take stool softeners. And basically, stool softeners function as a laxative. They're a little bit more gentle. So stool softeners are a little bit more gentle than what we would call the stimulant laxatives, which actually stimulate peristaltic activity. So stool softeners basically induce bowel movements by basically lubricating the stool. So they allow water to be drawn into the stool to basically make it softer. So one of the things associated with constipation is the very dry, hard stool. Stool softeners help to kind of reduce that. Um, Docusate sodium or cholase is a very common stool softener that people will take in order to do this. Again, this is kind of a more gentler type of laxative because it doesn't necessarily directly stimulate the gastrointestinal tract. It just softens the stool, as opposed to a stimulant laxative, which is it's a slightly more aggressive way to treat constipation. Senecot is one example, or any type of Senicides is a stimulant laxative. Magnesium citrate is another one. So, look at some other examples in the book, but those are some common stimulant laxatives. Again, there's potential risks with long-term use, and then there's some contraindications associated with stimulant laxatives if there's an inflammatory disorder, or again, if you're having a lot of pain with unknown origin. Remember, a lot of these things are more or less just treating symptoms, and this even goes back to the medications for treating diarrhea. And again, most of the time, diarrhea, constipation, it's caused by benign things, but you have to make sure that you're not potentially masking a bigger problem. And then we talk a little bit about opioid-induced constipation. So this is very common in individuals using opioids. Again, if someone's having fewer than 3 bowel movements a week and they're taking opioids, this could be a very common side effect of taking them. In some instances, you may need to take what's called a peripheral acting mu opioid receptor agonist. Because sometimes if the traditional laxatives do not work, so an individual who, for whatever reason has to be on an opioid a little bit longer, they may need to take this in order to kind of reverse the negative effects of the constipation. And again, note the contraindications for those particular medications as well. Gastroesophageal reflux diseases. So again, we discussed the pathology of GERD in the pathology video. So chances are you watch that first. If you happen to be watching this one first, you can get more of the information from that. So essentially, it's some form of reflux of the gastric content. So obviously, when you ingest food, there's the esophageal sphincters that don't allow the food to go from the stomach back into the esophagus for one reason or another. You get reflux of those contents. And again, the most common thing that people will complain about is that burning pain, that burning substernal pain. Again, that's something to be aware of as well. If somebody's, complaining of chest pain or something like that, again, you want to make sure that you obviously know the cause related to that. So other conditions that we kind of know as GERD, you may have heard some of these, again, the various terminology. So again, a lot of it just depends upon the mechanism of the disease. Again, if somebody is having very frequent symptoms, they want to make sure that, that they're at least seeing a physician and having that monitored for. So if it's simply just popping up every once in a while, a lot of the over-the-counter medications, a lot of the medications that we're going to talk about are available over the counter, but prolonged symptoms, they should be referred to for a definitive cause, or at least to be kind of monitored and followed. So a lot of the drugs that are used to treat this are used to decrease the gastric acidity. So probably some of the more common things that we look to treat, antacids, very commonly utilized, available over the counter. There's various types. Again, look at the different types of antacids described in the book. Have examples. Again, they're basically an over-the-counter medication that are used to neutralize gastric acid. So one of the big drug-to-drug interactions, they do affect the absorption of various drugs. So for instance, fluoroquinolone and tetracycline antibiotics, their absorption can be inhibited by this. There's various other types. So, something you could either do this now or later, pause the video, go look at what some of the other drug-to-drug interactions are. So be aware of those. There's also what are called non-absorbable types, which also tend to have fewer side effects and many times are preferred. So go and see what are the types of non-absorbable antacids that can be taken for this. Proton pump inhibitors, which are a very common type of drug utilized to treat gastric acidity. You know, one example of these is Nexium, a very common one that gets utilized. And what they basically do is this: they literally block the final step of gastric acid production. And many of these are available over the counter, so they can be given at higher dosages through prescription. You want to be careful using these for long-term use. So, and again, many times they will try to use the lowest possible dose. So the ones that are available over the counter have lower dosages than are typically prescribed. Even prescription, they can do lower doses, but then, which, you know, typically the physicians want to start with anyway. And many times they do prefer them to be used intermittently. However, some people do take them long term, but if they are being taken long term, that's something important to be kind of monitored with a physician. There's also the H2 receptor blockers. They're a little less potent than proton pump inhibitors. Again, they're actually going to still suppress gastric acid secretion. So again, but they are less potent. They have a range of 6 to 20 hours. These are a little bit more well tolerated, like I said, than proton pump inhibitors. Cimetidine, though, has some drug-drug interactions, so make sure to kind of, again, look at the different types of these and just kind of see and be able to recognize the different types. So be important to be able to differentiate, you know, the different types of antacids, proton pump inhibitors, and H2 receptor blockers. Gastritis and peptic ulcer disease. So again, gastritis is going to be an inflammation of the gastric mucosa. Obviously, peptic ulcer disease is when you actually develop the ulceration in the gastrointestinal tract. Both of these, both gastritis and peptic ulcer disease, one of the common causes of this is the Helicobacter pylori, which is a type of bacteria that forms. So, you know, obviously one of the ways this can be treated is through antibiotics to actually treat the bacterial infection. And again, both gastritis and peptic ulcer disease, various causes. Obviously, again, infection with the bacteria, drugs. Frequent use of non-steroidal anti-inflammatory drugs can cause this, along with various others. Stress, autoimmune phenomenon, so the body's immune system, so various autoimmune diseases can cause this as well. And again, NSAIDs, again, they promote mucosal lining inflammation and possible bleeding. So there's issues related. We'd already mentioned NSAIDs as a common cause of this. So because of their effects on the gastrointestinal system, they can promote and possibly cause both of these specific conditions. So in the case of someone does have a Helicobacter pylori infection, so again, this is a gram-negative organism and it thrives in acid. So that's one of the reasons why this is a common infection in the stomach, is because it can actually tolerate the acidity in the stomach. So the treatment for that, there's a couple different things they do. They utilize a combination of proton pump inhibitors and antibiotics. So there's an actual triple therapy protocol that gets utilized for this that's described in your text. So, you know, add that to your notes as you're kind of going through this. But that's the common way of kind of treating this, whether you're looking at a direct ulceration in the stomach or just a general gastritis that is formed. Gastroenteritis is an inflammation of the stomach lining. Various causes of this. This is one of the more common things that you will kind of see as it relates to people having sicknesses. Individuals, when they describe themselves as having a GI bug, if you will, is a common term utilized for this. It could be viral or bacteria. Most of the times that it is a viral origin, but it can be bacterial. So you have to look at, is it foodborne? Is it waterborne? Obviously, a lot of the viral versions of this, or the viral strains, are very contagious and can be transmitted person to person. It is uncomfortable, but it's sort of self-limiting. As you'll see, for the most part, treatment for this is usually pretty basic and standard supportive treatment. So we look at bed rest, rehydrate. Giving the example here, avoiding fruits. So fruits can cause obviously more frequent bowel movements with this, but you're going to want to do a pretty bland diet, particularly if you have gastroenteritis caused by a viral infection. So they talk about the very bland foods, or what they call the brat diet. So bananas, rice, applesauce, and toast is the brat diet. Many times that gets given for something like this, because you really want to make sure that you're not eating anything that's going to stimulate more bowel movements, and also you want to make sure you want to rehydrate. Again, always be aware of always have kind of C. diff in the back of your mind as well. Again, if somebody again has a lot of watery diarrhea, they've just recently been on an antibiotic and they start to have other symptoms associated with that, you want to make sure that you kind of always keep that in the back of your mind. So as it relates to gastroenteritis, neurovirus, which is a very common, stomach flu, if you will, that does circulate at times throughout the year, very communicable, particularly among teams. So in sports medicine settings, this is something where a lot of people this can travel through, a team or a group of student athletes very fast. It is very contagious. So again, the person will talk about gastric distress, nausea and vomiting. It comes on very fast, so it's kind of something that when people get this, they'll talk about how all of a sudden it just kind of hits them and they get very sick, feel very unwell. It also resolves very fast, so typically it does resolve within 48 to 72 hours. Some people may even get better in a little less time, but typically that's the usual resolution is about 2 to 3 days. Some people can usually start to feel better even after a full day of having symptoms. So your symptoms of this: fatigue, loss of appetite. You do have to be aware of dehydration. So if somebody has like another medical condition, that they're being treated for, and they develop a neurovirus, if you really want to try to avoid the dehydration. They'll typically have a low-grade fever if they have one. So again, make sure you should know the difference between a low-grade and a high-grade fever. But if they have a fever with this, it'll typically be very low-grade. Again, treatment for this, you're not going to treat it with antibiotics, and they actually suggest you don't. It's sometimes better to not use the antidiarrheal medications, because it can actually prevent you from kind of getting ridding of yourself of the virus. So you're better off just kind of sticking with just general hydration, and sort of just let it run its course. So for the 48 to 72 hours, like I said, it may even be less than that. An individual should just sort of like seclude themselves so they don't spread the virus, and then just sort of let it run its course, and they'll typically get better. So if you take an antidiarrheal, it's usually just for convenience sake, and it could kind of allow it to stick around a little bit more, prevent you from sort of ridding yourself of the virus. And then inflammatory bowel diseases. So again, it's a spectrum of chronic GI disorders. So we talked about these in pathology again. You look at things like ulcerative colitis, Crohn's disease. Those are different types of inflammatory bowel diseases. So again, they'll talk about individuals who have these will complain of obviously abdominal pain, bloating, distension, and various bowel habit abnormalities. So these are all different types of things that individuals will complain of. Again, so as you've seen in pathology, there's a lot of symptoms. So again, you kind of have to utilize in your pathology text gives you those nice little algorithms that you could kind of look at, and I encourage you to look at those to kind of see even clinically how to manage somebody who initially starts to complain about, abdominal pain. So, do they have frequent abdominal pain? Is it acute? And that kind of tells you how to kind of manage it. Your general treatment for inflammatory bowel diseases, again, typically to start with, you'll always look at diet. So avoiding things like lactose or possibly gluten as a trigger for the inflammatory bowel disease. You can treat the bowel symptoms using all the previous described agents. Again, in some situations with inflammatory bowel diseases, there may be some things that individuals don't prefer. Again, I would encourage you to go back and look at and connect the various symptomatic treatments that can be utilized for this, so based on what we've already talked about. And then there's other types of medications as well that are a little bit more specific for treating the actual pathology of inflammatory bowel disease. So 5-aminosalicylic acid is one, corticosteroids to treat the inflammation. There's immunomodulating drugs that can treat the actual autoimmune effects related to these. There's biologic agents that can be used, and then there's antibiotics and probiotics potentially depending upon the individual situation. So in summary, again, generally when you're looking at gastrointestinal issues, so again, supportive care and general management of GI disorders. So look at what some of the general management tips are. There's a little section in your book on that. We kind of already did talk about some of them. And the thing to be mindful of, they're going to be helpful for most of the conditions that we look at. So just from a clinical perspective and kind of empirically sort of treating individuals who come to you with GI complaints. Again, the key is being able to sort of pick out if signs and symptoms that could potentially lead to a slightly bigger problem, which is the reason why in sports medicine we learn about these things. So again, nausea and vomiting, there's multiple etiologies that can cause that. So again, it's kind of narrowing down the cause as to what you're actually looking at. Most conditions are reversible, and you'll notice in this chapter, a lot of these medications are available over the counter. So multiple non-prescription treatments. Obviously, there are some things that require prescription or will be used in the hospital setting in certain situations, particularly as it relates to IV and intramuscular injection. You do have to be aware that the chronic conditions, for instance, like inflammatory bowel disease, that does eventually cause damage to tissue. So that's why it's important for them to get diagnosed kind of early and treat it, and then the individual, taking the appropriate, whether it be the medications, dietary changes. And again, it's, like many things that we talk about in this particular course, it's important for us to be aware of this. Yes, these aren't conditions that we necessarily can diagnose clinically or that we'll even have a full hand in treating like many of the musculoskeletal conditions, but we're, as medical professionals, we're responsible for providing supportive care and advice for these things. And many times in traditional sports medicine settings, your athletes are actually going to come to you potentially before they go to anybody else. So, in school settings, even before they go to maybe like even a school nurse or just even go to their doctors, they're going to come and ask you. And again, obviously, work within your scope of practice and still do an assessment and see what their issues could be and refer if necessary. But, many times, and I may have mentioned this before, students many times will say, well, why are we learning all of these types of pathologies where, our expertise is in musculoskeletal conditions, which that's true. But again, we're healthcare professionals. We're in work settings where, individuals are going to come to us discussing these things. So it's important for us to be able to provide that. And these are our objectives for this particular chapter.